Hello and welcome. Thank you for choosing CCED seminars for your chiropractic continuing education. Before we begin, here are a few quick tips to get the most out of your course experience. At the bottom of the video, you'll find your controls. Click play or pause as needed and use the speaker icon on the bottom right to adjust your volume. For our hearing impaired participants, closed captions are available. Just click the CC icon to turn them on. Want to speed things up or slow it down? The gear icon also lets you adjust playback speed to match your learning style. Need a bigger view? The full screen icon on the far right will expand the video for a more immersive experience. And don't worry if life gets busy. You can pause the video anytime and return later, even days later. Just make a note of your place or take a screenshot for your records. Your access to this course video will remain available for approximately 1 year. Feel free to revisit and review the material anytime at no extra cost. Keep in mind, CE credit is granted only once per course. From all of us here at CCED Seminars, we wish you good health, continued growth, and great success in your practice.
Welcome, doctors. Thank you for attending class tonight. We have a busy schedule here, so we're going to jump right in. We're going to talk about the shoulder injuries, athletic injuries that occur in the shoulder, and we're going to go over diagnosis, treatment options, and so forth. I'm going to start off with the guideline for diagnosis and treatment of subacromial pain syndrome. This is a nice position paper put together by the Dutch Orthopedic Association. So we'll go through this and talk about it. So subacromial pain syndrome is defined as all non-traumatic, usually unilateral shoulder problems that cause pain localized around the acromion, often worsening during or subsequent to lifting of the arm. So like if we're doing a NIRS test or just abduction at 90 degrees, usually they have pain in the shoulder. The different clinical and or radiologic names such as bursitis, tendinosis, calcarea, supraspinatus tendinopathy, partial tear of the rotator cuff, biceps tendinitis, or tendon cuff degeneration, all are part of this syndrome. Treatment for subacromial impingement syndrome of the shoulder has changed drastically over the past decade. We've seen this, you'll see this clinically. You know, we used to use a lot of ultrasound and electric stim. Now we have other modalities, you know, such as laser. We have extracorporeal shockwave treatment in our offices, and that works very well. The anatomical explanation for impingement of the rotator cuff is not sufficient to cover pathology, so the subacromial pain syndrome describes it better. It's an all-encompassing term with those situations like tendinosis and tendinopathies and so forth, and bursitis. Working group formed from the Dutch specialist societies joined by the Dutch Orthopedic Association has produced a guideline based on the available scientific evidence. This resulted in a new outlook for the treatment of subacromial pain syndrome. What's interesting about grabbing like European studies is they look at things a little bit different than we do, so we can learn something from them. The important conclusions and advice from this work are as follows. The diagnosis of SAPS can only be made using a combination of clinical tests. There's not one single test that you can make the diagnosis with. SAPS should preferably be treated non-operatively, which is great for us because between chiropractic and physical therapists, you know, we're the ones that treat this condition, and these patients need our care. Subacromial injections with corticosteroids is indicated for persistent or recurrent symptoms. Usually if the symptoms persist for more than 3 to 4 weeks and not getting anywhere in your initial treatment plan, it may be a good idea to get a cortisone injection. I'm not a big fan of cortisone injections into tendons because patients tend to feel better and then they go back into daily routine without rehabilitation, and then that's how they can tear the tendon further or just tear it completely. Diagnostic imaging is useful after 6 weeks of symptoms. Ultrasound examination is recommended imaging to exclude the rotator cuff rupture. We're going to go over the differences between MRI and ultrasound. We know in the United States that MRI is the gold standard. It's very difficult to find ultrasound usage or sending someone to a diagnostic center where they have ultrasound, where you're going to get a reading and so forth. But you'll see in the coming slides that ultrasound is very sensitive to diagnosing this. Occupational interventions are useful when complaints persist for longer than 6 weeks. So we see maybe ergonomic changes that can be made. I always go over this with my patients. People tend to reach for their mouse, which aggravates this situation. Let's go continue here. Exercise therapy should be specific and should be of low intensity with high frequency, combining eccentric training, attention to relaxation and posture. Posture is important. We know that with the protracted scapula that sets up for impingement syndromes and so forth. We will cover that tonight. And treatment of myofascial trigger points. Classically, you'll find them throughout the rotator cuff. You have to look for them. One of the most overlooked areas is the subscapularis. If you have a supraspinatus impingement syndrome, you have to check that subscapularis. Typically, it's loaded with, well, not loaded with it. They only have 1 to 2 trigger points in that in the subscapularis, but the range of motion, abduction and flexion, can be hindered because it's such a strong adductor, and you want to make sure that we can get some stretching on that. It's part of the therapy we want to do. Tendinosis calcarea or calcific tendonitis. You can see this on the supraspinatus tendon. You'll see this typically in older population. You won't see it in your younger athletes. You'll see more someone definitely over 50, especially if they've been involved in athletic activities throughout their lifetime. The extracorporeal shockwave treatment and needling under the ultrasound guidance are two treatments that can help break that up. I can tell you that we use the extracorporeal shockwave treatment in our office, and I've used it on this condition on quite a few patients, and it does work well. Rehabilitation is a specialized unit, can be considered in chronic treatment resistant SAPs with pain perpetrating behavior. I think you have to rehab everything from a sprained ankle to a ACL injury, or even with when you're getting into injuries around the hip, but definitely with the shoulder too. I mean, the shoulder, you got band exercises and postural exercises are probably your best way to go. They're low tech, and I see that that the benefit from those exercises is tremendous, and it's right up the alley for most patients. You really don't need to use weights if the patient's at the point where the patient is ready for weightlifting type of thing. I have relationships with some personal trainers, and I usually send them to them with some instruction. I don't need to have a weightlifting gym in my office. I can rehabilitate patients with low tech. There's no convincing evidence that surgical treatment for SAPS is more effective than conservative treatment, which is, again, good for our purposes, unless, of course, it's a complete tear. I mean, that's something that definitely needs to be reattached. There is no indication that surgical treatment of asymptomatic rotator cuffs. So that's interesting. Okay, some clinical questions in this paper. What is known about the prognosis of SAPS? The longer the duration, the poorer the outcome. If it's been going on for 3 months, you're probably dealing with someone that's not going to respond too well. We may have to go to the next phase. By this time, though, you should know. I mean, I don't let it go past 6 weeks before I do either MRI or ultrasound. You should know at that point, that 4 to 6 week window. If they're not improving, you got to get some. You definitely have to get some imaging. And in the beginning, I do X-rays because if they have, first of all, I want to see if it's a calcific tendonitis, or I want to see if there's any degenerative change in the shoulder joint. There may be some. They may have a type 2 or type 3 acromion, which is not a good indicator, and you see that in the third bullet point there. Or they may have, a bone spur, subacromial bone spur or something, which is clashing into the tendon, and it's never going to get better because they're constantly hitting it. So that sometimes does require arthroscopic surgery, and they got to go in there and clean it up with doing a acromioplasty. So, yeah, type 2 and type 3 morphology of the acromion. I don't know if you're familiar with that, but it has to do with a curvature of the acromion. Instead of being straight out, they curve downward. There's less subacromial space, so hence you have a poor outcome with these patients. Clinical question number 2: what measures are effective in preventing this? What methods are effective? Well, repetitive movements of the shoulder or the hand and wrist during work. Someone that's, like I said, how many of our patients, maybe be weekend athletes, and but during the week they're behind a computer 40, 50 hours a week, and their posture is probably not good. They're reaching for their mounts. They're hunching over the computer, getting a protracted scapula, setting themselves up for this situation. Work that requires much or prolonged strength of the upper arms. That's for us chiropractors, adjusting patients all day. Hand-arm vibration. People that work with vibrating tools and so forth. Carpenters, saws and jackhammers and whatever they're doing. That could be a situation that can lead to problems with the rotator cuff. Working with a poor ergonomic shoulder posture, which we talked about. A high psychosocial social workload. So they're finding that there's that can be associated with shoulder complaints, low control, low social support, low job satisfaction, high pressure to perform. I guess that's something that they found that probably, I would imagine, would change posture of the patient. Clinical question number 3: which physical diagnostic tests are most accurate, sensitive, and specific for subacromial pain syndrome of the shoulder? So their scientific evidence shows that no single test is sufficiently accurate. I mentioned that earlier. You have to use multiple tests. If you go down to their recommendations there, where I bolded that, to determine SAPS, a combination of Hawkins-Kennedy, painful arc test, infraspinatus muscle strength test should be used for rotator cuff tear. The drop arm test and the infraspinatus supraspinatus muscle strength test should be used if you're looking for a complete tear. So partial tear, typically Hawkins-Kennedy will identify this with a painful arc. Also, the supraspinatus test, reaching the inferior scratch where they reach behind their back to touch their lower back. Not very specific, but it is sensitive. And of course, you could do, if you do O'Brien straight out in front, or an empty can with horizontal abduction, which we're going to go over. Those tests are very sensitive and specific. But you have to get a couple of positive findings, not just go off from one test, say, okay, I got a tear here. Okay, clinical question number 4. What is the added value of imaging tests for diagnosis of SAPS? Well, their scientific evidence level 1, the sensitivity and specificity of ultrasound and conventional MRI are not significantly different in the detection of partial or full thickness rotator cuff tears. What they did find out, though, is that for a complete tear, is that the MR arthrography is better to rule out, partial rotator cuff injuries, where it is likely that the ultrasound is accurate method for the detection of or exclusion of a rotator cuff tendinopathy, subacromial bursitis, bicep tendon rupture, and tendinosis, the calcarea or calcific tendonitis. So the ultrasound is very sensitive for that. Clinical question number 5, which instruments are most suitable for measuring the outcome of the treatment? So these are your outcome measures. Of course, goniometry or inclinometry, doing those range of motion testing is important. But they also highlight the DASH being very sensitive here. So the DASH is that outcome questionnaire that you could use. They also do the English Oxford shoulder score test. Never used that myself. I use the DASH in our office. And of course, objective findings. Okay, clinical question number 6. Which non-operative treatment is most effective for patients with this condition? So, non-operative treatment in the first 8 weeks, corticosteroid injections are more effective than placebo injections. Physiotherapy or no treatment in reducing pain and improving shoulder function. So the injections work for pain relief, but like I said, if it's not going to correct the biomechanical problems that led to this, so that's why we have to do the rehabilitation. Extracorporeal shockwave therapy is more effective than the high energy is more effective than low energy than a placebo and reducing pain and improving shoulder function. It does work well, and it can break up some of the calcific tendonitis. So it is something, I don't know if you're familiar with that, docs. You can raise your hand if you used it before. It's excellent. It's an excellent modality. All right, take a sip of the old coffee there. All right. Other therapies. Exercise therapy is more effective than no treatment in reducing pain, improving function of the shoulder. Again, well, the exercise, the massage, which is the next thing that they highlight, these are more effective because we're addressing the biomechanics. Oral NSAIDs appear to be more effective than placebos. I'm not a big fan of using oral NSAIDs for long-term usage. We know the problem with stomach and kidney with them, but also they can slow soft tissue healing. Studies have shown that. Other therapies, laser treatment appears to be more effective than placebo or ultrasound treatment in reducing pain after 2 to 4 weeks. What's really interesting is that I didn't start using laser till I really came down to Florida. When I was in my clinic in Virginia, my favorite therapy for treating this condition was ultrasound combo therapy. I don't know, it just seemed to work very well. That with rehabilitation, I got great outcomes utilizing that. But they're saying here, they're citing that the laser is definitely more effective than the ultrasound in reducing pain after 2 to 4 weeks. Ultrasound treatment, they're saying, is no more effective than placebo. Again, this is their paper. Clinically, I disagree with that. Electric stimulation has not been shown to be more effective than placebo. I don't use a lot of electric stim, maybe just ice and stim for acute swelling and pain relief, and usually interferential is what we use. But other than that, we're more into manual therapy in our office. We do a lot of manual therapy, a lot of stretching. I've with the diplomate. I'm trained in Graston and ART. I do that with patients, so a lot of kinesio taping. Clinical question number 7. When is surgical treatment for SAPS indicated and which technique is preferred? Scientific evidence level 2. It has not been shown that surgical treatment for SAPS is more effective than non-operative management to improve shoulder function or reduce pain. No difference in outcome for shoulder function complications, and it has been shown between arthroscopic approach or open approach. A bursectomy, which is when they take the bursa out, is likely to give the same clinical outcome as a bursectomy with acromioplasty, and that's when they clean up that area. Now, is there a place for surgery? Absolutely. Like we were talking about before, there's some degeneration, or if they have a type 2, type 3 acromion, there's some bone spurs, acromioplasty, they clean up that, make more room in the subacromial space, give more room for the tendon. Makes a lot of sense, especially if they want to stay active. But just, the first treatment in the first 8 weeks should be manual therapy, massage, or whatever you want to call it, exercise rehabilitation, laser treatment maybe for pain relief, shockwave treatment for the calcified tendon or a chronic situation that's not responding after 6 weeks. Ultrasound combo therapy worked well for me in all my years of practice. So I don't use it anymore because we have laser, but it's good.
Dr. O'Hara, I'm sorry to interrupt. We have
Yeah.
a question from Dr. Richard.
Okay.
I don't know if you can see that.
I don't see
over
it.
in the Q&A.
No, let me see. Hold on. There it is. Any specific settings? That's all I get. Let me see. Any specific settings for laser rehab, post-surgical repair, or full thickness supraspinatus tear and bicep tear? Good question, Doc. Unfortunately, my laser settings are preset when the guy came out, so I can't give him off the top of my head. I can check that on my laser and get back to you, but everything's set up. We have, for shoulder pain, elbow pain, so forth. Obviously, the treatment time's usually around 10 minutes. I can tell you that, but I don't know the specific settings off the top of my head. I can research that for you and get back to you. You just shoot me an email, and you'll have my email at the end of the presentation. Treatment algorithms. To-dos in this treatment algorithm. Okay, so a diagnosis of SAPS can only be made after the combination of tests. We talked about that. Hawkins-Kennedy test, painful arc test, infraspinatus muscle strength testing, O'Brien's test, Speed's test, things to rule out. If you think bicep tendon is involved, you got how's the Speed's test, Jurgensen's test, these types of things. You need to be specific upon your diagnosis. Know which tendon is involved. Define the lesion so you can treat it properly and get a better result. Is it preferable to treat SAPS non-operatively? It is preferable to treat non-operatively. Treat acute pain with advice, explanation, possible analgesics for a maximum of 2 weeks. I agree with that. After 2 weeks, you don't need to. If symptoms persist longer than 6 weeks, take steps in the workplace to prevent development of chronic syndrome. Again, ergonomics. And I go over ergonomics early with my patients. I don't wait 6 weeks. I know with my patients that come in who, ask them what they do for a living, how they, even when you're dealing with someone like low back pain, neck pain, so forth, what are you just going to do? Push down the bumps and send them out to the office? They're going to come back again and so forth. I like, most of our patients, I've done biophysics in the past and so forth. I do not do it now. Not that I don't agree with it. I love it. I loved it. Probably the most fun I had in practice. But our clinic's really an acute care clinic. We do a lot of managed care, so you have to get the patients out like within 8 visits. Yeah, we have personal injury patients, and we have you know, we treat vets in our offices and so forth, but for the most part, most of our insurance patients are 6 to 8 visits. So, all right. If symptoms persist longer than 6 weeks, take steps in the workplace to prevent development of chronic syndrome. We just talked that. Prescribe therapy or home exercises. Always try to do that. Try to keep them compliant. At least give them some stretching they can do at home. Eccentric training, I like to do, with bands in the office. A lot of times when people are doing band exercises, they like to show, the concentric training, but really focus on proper form, and also have them do eccentric training. One thing great about a band is that you can do eccentric training with it, because there's resistance if they slowly go back to the starting position. Treatment of myofascial trigger points, we talked about that. Persistent symptoms, subacromial injections. Again, now you're at the 6 week point. You might be looking at, imaging. They're not getting much better. You're going to send them for imaging or maybe possibly for orthopedic referral. If symptoms persist longer than 6 weeks, ultrasound can be, we talked about that, MRI. Like I said, MRI most likely in our case, because it's really hard. I don't know if it's that way in Texas or the state that you practice in, but in Florida, there's very far and few between diagnostic ultrasound for musculoskeletal. It don't seem, I guess it's not a moneymaker for them, I guess. I don't know. It's less expensive than MRI. Typically, the test is, $300, $200 to $300 reimbursement, I think. For tendinosis, calcarea, the shockwave treatment, or the barbotage with the needle. Again, shockwave treatment works. I don't know. We can't stick needles in tendons unless you're acupuncture. Dry needling works great for trigger points. I do not do it. I wish I was certified in it, but it really wouldn't matter down here in Florida. You have to be certified in acupuncture to do dry needling. Indication for surgical repair of a symptomatic rotator cuff tear depends on the size of the tear, the condition of the muscles, and the age of the patient. And usually they don't do much for people over 60. Usually they're looking at younger population or athletic population. The don'ts: strict immobilization. See that a lot, still. And I can't believe it. The patients, one guy got hit. It's not an athlete, but this guy he was on his bicycle, he got hit by a car. And he fell onto his acromion. And I'm still trying to get the x-ray report from the hospital. But supposedly he fractures the acromion. They have him and they have his arm, taped to his side. And when he comes in the office, we take it off, and we've been doing some passive motion with him and doing some manual therapy on the shoulder. But it's like, if it's fractured, I would think that they would do they would be more apt to send me over their report right away. Limiting imaging to conventional radiographic examination. That's to rule out that we do that in the beginning, but they're saying you just don't want to limit to that. Of course, if you're getting to a point when that case was 4 to 6 weeks and you're not getting that improvement you want to see, you want to get the ultrasound or MRI. Ultrasound examination with suboptimal technique and experience. Yeah, well, we're not doing it. We're sending out for it. Some doctors, some larger sports clinics do have ultrasound in their offices. Extracorporeal shockwave treatment in the acute phase. So you're not going to do that in the acute phase. Like I said, we don't institute that typically unless it's a chronic non-responsive. Same thing we use that for plantar fasciitis, and I went over that in my foot webinar that when we were talking about plantar fasciitis, that extracorporeal shockwave treatment is usually a phase 2 treatment when they've past 3 months of having it, because you're really trying to break up scar tissue and so forth, try to get better range of motion and so forth. Surgical treatment without exhaustive non-operative treatment. So they don't want you doing surgery without exhausting the conservative treatments. All right, this was the NEARS test. A reason why I grabbed this picture, because a lot of people don't do this test properly, but if you notice, he is stabilizing the scapula as he does passive flexion of the shoulder, and you want to check to see if the patient had pain. What is the degree of that he has the pain, that the patient has the pain at? You know, this person's at like what, 140 degrees maybe, just eyeballing that, 150 degrees. That's pretty high. Typically, someone with a really inflamed shoulder, you get to about 90 or 100 degrees, and they have pain. This is Hawkins Kennedy. It's kind of like a Kimura. I don't know if I worked at MMA for 6 years, so it does submit people, even if they don't have SAPs. But this is what you're doing is you're internally rotating, and then you're doing kind of rotating the glenoid tubercle up against the subacromial space to try to impinge that supraspinatus muscle.
We do have one more question for you there, Dr. Jeff.
Okay. Thank you. Patient position while doing extracorporeal shockwave with movement. No, it's not, Jeff. It's not something you do with movement. It's more of it's a passive therapy like laser or ultrasound. They may move while you're doing it because it is painful, especially high energy. They will feel it, and we do instruct patients to that event. So, but usually I have them lie on the unaffected side, so the shoulders up. Use ultrasound gel over the area, and we search at a low frequency. When we come up, when you're searching the area and they identify the painful point, then we increase the frequency and we get them to we blast out that point, and they'll tell me, like for instance, they'll say that that the pain is dissipating, and once the pain dissipates to a point where it's almost gone, then we move on to the next point. So and sometimes it's multiple points within the same tendon, you know, where you're working on. Okay, O'Brien's test. I very sensitive test. It's an empty can test. You can see how the thumb is pointing downward, 10 degrees of adduction of the arm, and you put pressure down. You're not trying to kill the patient. You know, remember when you do your muscle testing, it's very light pressure. You don't have to push hard. It's just enough to get a good contraction, and if there's an injury or an insult to a lesion there, you will get a positive result. Excuse me. Now with O'Brien's, you see on the B part of O'Brien's is a speeds test. So we're trying to differentiate between, now O'Brien's also is differentiates for slap tears. So if you know, a slap tear is a long head of the bicep where it attaches to the anterior labrum in the shoulder. So if that that pulling will actually with the empty can in front like that actually causes a lot of pressure on that area, and if it's there's a lesion there, it's going to cause pain. If you have them pronate their hand and you go into a speed situation, the pain would be different. And you want to palpate. One thing they're not doing here, I don't stand behind the patient here, I stand to the side. I palpate the bicep tendon when I do the speeds test. Because I want, you know, if they're saying yes, that's painful, I'll even try to identify on the tendon where the pain point is. So, yeah, patients think I'm a little sadistic because I'm sure yours do too. When you always find the painful points, they ask, you know, did you have a class on that, doc? Yeah, we did. A few classes called palpation. All right, this is diagnostic ultrasound. The sensitivity and specificity of ultrasound and conventional MRI are not significantly different for the detection of partial or full thickness rotator cuff tears. This is a long axis study. Long axis meaning that here's the end of the supraspinatus out here, and this is the tendon, okay? And then we go into to where the muscle tendinous junction here. Most tears occur here, and you can see they mark the beginning of the tear and the end of the tear. This is the longitudinal tear in the supraspinatus muscle here. And now this is the short axis, so now we're kind of turning the head, so we're looking at more perpendicular to what we just saw. So now you can see here's the bicep tendon. All right, we didn't see that before. Here's the partial tear out here. Okay, they're saying some delamination going on here within the tendon. Cortical margin, they're identifying the cortical surface and the margin here. You see there's some spacing occurring there too. Here's again another long axis, and here's identifying the tear here. You see the empty space here, okay? And then up here you can see the differences in contrast here. So you see the deltoid muscle over the supraspinatus muscle, the humeral head, which, okay, but you see the fascia and the fat and everything is a little lighter. The muscle is more dense. And you're looking for, like an MRI, we're looking for contrast changes in the area. And it's what's really funny. I mean, I practiced in New York, and that was from '99 to 2006. I had a company that used to come to my office and do, they did the surface EMGs and they did diagnostic ultrasounds. And there was such an uproar about these companies doing this. And meanwhile, they were ahead of the time for diagnosis. Surface EMGs, there's always a question of whether or not they're, how accurate they were and so forth. But the ultrasounds, you go over, like you have like a car accident patient, and they were going over the facet joints of the neck, and you can see the inflammation in the facet joint in the capsule. You could see the swelling and so forth. And I thought it was very beneficial. And then I hear, of course, being around sports medicine and stuff, I used to have them come in and do shoulders for me, elbows. I've seen um, tennis elbow. I've seen tears out there, so forth. It's just funny. It was a great service. Now here's the MRI. And of course, it's much more defined. You can obviously see the tendon clearer. You can see the tear. I would imagine this is an arthrogram because it looks like there's some brightness here. There's some contrast in here, and you can see the contrast in the tear here. Now, what's the partial tear and what's a full thickness tear? And so forth. So full thickness is through the thickness of the tendon, okay? So this goes from one side to the other side. That's a full thickness tear. Partial tear could be that there's it doesn't go all the way through. And a complete tear is when you'll have a complete avulsion of the tendon, okay? So know the differences when you're getting these reports back. There's your avulsion. It says full thickness tear, but that's an avulsion tear because that's not even the tendon's not even attached. The gadolinium's going underneath the tendon here. So I would argue that is it's a full thickness tear, but it's also a avulsion tear. It's a complete tear. That's the surgical situation right there, folks. All right, here's the infraspinatus tendon. Okay, remember off the back, now you can see we're way up here is the top of the shoulder. And so this is the posterior aspect. Spine and scapular is probably right here. This is the tendon. You can see that the tear is like in the muscle tendinous junction here. Not so much out here where we see like supraspinatus is always typically on the out of 1/3. Infraspinatus, subscapularis, you can see, tendinous junction tears. And here is the subscapularis. There's the bicipital groove, okay? There's the bicep tendons dislocated. The subscapularis crosses up and over, okay? And when it tore, it took the tendon with it. And the subscapularis tendon end is over here. It's not, look how far away from the humerus it is, So, that's nasty. That's a nasty fix, but that's another surgical fix. Let's touch on some research on this topic. It's about 8:42 my time. So shoulder rotator cuff disorders, a systematic review of clinical practice guidelines and semantic analyses of recommendations. Now, I highlighted here in the bold that all clinical practice guidelines recommend active treatment modalities such as an exercise program in the management of rotator cuff disorders. Acetaminophen and/or NSAIDs prescription and corticosteroid injections were presented as modalities that may be recommended to decrease pain. Recommendations related to medical imagery and surgical opinion varied among the guidelines. The most common recommended return to work strategies included intervening early, use of multidisciplinary approach, and adaptation to work organization. We were talking about that before in the last paper. Help your patients out, educate them on ergonomics, and so forth. Can clinical assessment differentiate partial thickness rotator cuff tears from full thickness rotator cuff tears? A secondary analysis. Thought this was pretty interesting. It was just came out last year in 19, and their objective was to determine if the clinical assessment framework could discriminate between patients with partial and full thickness tears. What they found is that greater abduction strength, what they call the constant power score, was associated with partial thickness tears, which makes sense. I mean, if you have a full thickness tear, it's most likely there's less fibers attached, there's less strength in the muscle, more pain. Going down a little bit, it says most findings within our clinical assessment framework did not distinguish between partial thickness and full thickness rotator cuff tears, and thus did not contribute to a differential pathoanatomical diagnosis. Since structural integrity of the rotator cuff and patient presentation show poor association, and rehabilitation intervention is often impairment-based, pathoanatomical diagnosis may not adequately direct non-surgical treatment. It's a pretty strong statement. Basically what they're saying is that if you're when in doubt, rule it out, get the MRI and make sure that that they're not full thick. What you don't want to do when you're working with these patients is cause further damage. So, and we always go from passive range of motion to active assisted range of motion to active range of motion. Sometimes I hear these stories, these horror stories, that these patients come to me and they tell me about their shoulder rehab with physical therapists, and I hear they have them doing the UBE, that circle bicycle thing, and they have them doing all these exercises, and they're doing light dumbbells. I'm like, did you do bands? And no, we didn't do bands. I'm like, okay, you just started there yesterday. You really, slow and steady wins the race. You don't want to injure these patients. Okay, rehabilitation after rotator cuff repair. So this is after the repair. They say a successful outcome is much dependent upon surgical technique as it is on rehabilitation, which is interesting. So if you're working, you have a working relationship with an orthopedic who's going to be seeing your patients, make sure you want to know, like, okay, so what kind of technique do you use? Educate yourself a little bit, on their approach. Or make sure that they're working, doing the best job for your patients. Okay. However, they talk about there is no statistically significant differences between a conservative and/or accelerated rehabilitation program. Early passive range of motion following arthroscopic cuff repair is thought to decrease postoperative stiffness and improve functionality. However, early aggressive rehabilitation may compromise repair integrity, which makes sense. Scar tissue formation takes 14 to 28 days. You're not going to want, most of the time when they have rotator cuff repair, they're in a sling for 28 days or 4 weeks at least. Conclusions are a gentle rehabilitation protocol with limits in the range of motion and exercise times are after arthroscopic rotator cuff repair would be better for tendon healing without taking any substantial risks. So, gentle. Arthroscopic surgery of the shoulder in the management of partial tears of the rotator cuff, a preliminary report. Just go to the bold area here. Not only can a partial rotator cuff tear be debrided to initiate a healing process, a response, but a definitive diagnosis can also be made. An associated pathology identified, permitting the establishment of an appropriate rehabilitation program. So there, before MRI, that's what that was their diagnostic choice, was to do arthroscopic surgery, go in there and look at the tendon. So then MRI came out and they stopped doing that primarily, but they're saying that going in and doing the surgery, they can help debride it and start the healing process. Functional recovery after rotator cuff repair, the role of bicep surgery. Interesting situation here. They're saying that there are more failed surgeries when they repair the bicep tendon, because sometimes there's a concomitant biceps pathology present with the rotator cuff, and I don't know how familiar you are with your patients, if they've had patients who've had surgery like this, but what happens a lot of times, they don't fix the bicep tendon, the long head tendon. They leave it detached. They don't really need it for flexion. You got the short head for elbow flexion, and you also get the some other assisting muscles, but you also it helps repair. They found here, they said 93 consecutive patients had undergone surgery for full thickness symptomatic rotator cuff tear were enrolled for rehabilitation. 25 underwent rotator cuff repair and tendon bicep surgery. 68 patients just rotator cuff repair only. Then we'll go to the next one. Did I say patients with rotator cuff repair and tendon bicep surgery had lower final scores, effectiveness, and efficiency in constant score than those with rotator cuff repair only at the end of the rehabilitation. The study highlights that concomitant tendon bicep surgery negatively affects functional outcome of patients who underwent rotator cuff repair. So that's pretty strong. Vince, hey, welcome, Vince. That's where we're going to break. We're going to come back. We'll go over labral issues. Vince, you got those questions there, buddy? You there?
I do. I got them.
All right, docs, when you're examining the shoulder, which of the following tests point to impingement. Nears, Hawkins, Kenny's, O'Brien's, apprehension and relocation, all the above, none of the above. I don't think we talked about apprehension or relocation, so that should be a little hint for you.
All right, those answers are flying in, so we're only missing a few. I'm going to give about 10 more seconds for responses. All right, there you are, Dr. O'Hara.
Yes, thank you, Vince. Nears, Hawkins, Kenny's, O'Brien's. That's what we talked about. So let's go to apprehension and relocation. We're going to talk about with labral tears. That's those necessary there. Dislocations also. Which imaging modalities demonstrate rotator cuff tears the best? X-rays, diagnostic ultrasound, MRI, or BNC?
And there you are, Dr. O'Hara.
Thank you, Vince. BNC docs, we talked about MRI, diagnostic ultrasound in that first study we looked at, being both very sensitive and specific for rotator cuff tears. We're going to take a break. If you have any questions, well, there are some questions here. You know what? Let's take a break, and when we come back, I'll answer the questions.
All right, doctors,
Thank you, Vince. All right, docs. I guess there weren't questions. I think there must have been answers you threw into the Q&A session there. So let's jump back in here. We're going to go over some labral lesions. There's the slap tear, which we talked about, which is a superior labrum anterior to posterior tear. You got the posterior labral tear and a posterior labral fraying. So the slap lesion occurs where the bicep tendon anchors to the labrum. Common injuries in athletes. You'll see this often in sometimes in throwing athletes. You'll see it also with forceful abduction and extension of the arm, external rotation. Presentation: the patient presents with pain in their shoulder, tends to be deeper pain, and they may have a click upon certain movements. Limited range of motion with pain is possible. Inflection and abduction with rotation. Positive orthopedic testing includes O'Brien's. Nears can be positive, speeds can be positive, empty can, and supine apprehension. Excuse me there. Shoulder x-rays, most likely negative. An MRI is best to view these lesions with contrast medium. This is a video of O'Brien's. I don't know, do you have this loaded, Vince? Yep.
O'Brien's test. This is a test to determine if there's labral tear, possibly a slap lesion. The O'Brien's test, you're going to have the patient elevate the arm about to 90 degrees of flexion with internal rotation and about 10 degrees of horizontal adduction. I'm going to ask the patient to resist this position. If this is painful, I'll ask the patient to externally rotate and resist that position. If this relieves the symptoms, you would have a positive O'Brien's. Again, the patient is going to have pain with internal rotation, horizontal adduction with resistance, and no pain with supination or external rotation of the shoulder. This would be indicative of a possible slap lesion, labral tear.
All right, so we talked about that earlier, but he's correct. So what he did there is do the second part of that O'Brien's test is the speeds test, and he has he almost choked. Me too, Vince. I've got a little frog in my throat. I don't know what's going on here. And that should be negative because you're not putting pressure on that bicep tendon. Not the area where the lesion is, of the labrum there. Okay, let's go on to the next slide. This is speeds test here again. You're testing for bicipital tendinopathy. Can also be positive slap tear, which contradicts what that guy just said. But it's not for slap tear. It's for bicep. Remember, like I said, you want to palpate the bicep tendon. I want to try to locate the lesion there. You want to be specific, okay? This is the empty can test. The empty can test is more for finding the supraspinatus tendinopathy, but you can also be positive with a slap tear. Now here's an MRI. This is the glenoid, okay, and obviously the labrum is this dark area here, and you can see where there is a tear right there. This is the labrum here too, so it's got pulled away from the glenoid. And that's the slap lesion. So you're gonna see that, and when we go into a little rehab in a little bit, we'll talk about rehabbing that versus the posterior lesion. Excuse me for 1 second, docs. I had a little frog in the throat there. Okay. Posterior labral tear. Presentation: patient presents with posterior shoulder pain, worse with pushing moments, bench press, side posture adjustments for fellow chiropractors. Pain at the end of range of horizontal adduction, not abduction. Positive supine shoulder apprehension with external rotation. So when you have them lying supine and you have the arm in abduction and external rotated, and when you go to extend that and you start rubbing against that posterior labrum, that's going to be painful. May have weakness in the external rotator cuff muscles, your teres and your infraspinatus. You'll definitely have trigger points in those muscles. Shoulder x-rays may reveal slight joint space narrowing along with spur formation. MRI reveals labral tear, best seen on the axial images. And here it is. Okay, here's the glenoid. There's the superior labrum right there. Here we're coming down here to the posterior aspect, and you can see the tear in the posterior labrum here. Okay, bicep tendon's all the way over here. See the groove, bicipital groove. There's the tendon. Now here's some fraying of the labrum. Okay. And this is more of like a degenerative situation. So with, weightlifters, 30 years of side posture adjustments, stuff like that. All right, passive therapies. Ultrasound, interferential ice, so forth, soft tissue massage. I mean, you're going to work on the rotator cuff muscles. You're going to try to increase flexibility of the shoulder girdle. So you may be doing more than just the rotator cuff muscles. Remember, don't forget the subscapularis, the serratus anterior, the pectoralis muscles, your rhomboids. You want to work all the way around there. You want to try to free up any adhesions in the muscles, trigger points, so forth like that. Cold laser therapy is good for healing. Passive range of motion within pain-free range of motion. So passive range of motion is exercise only in pain-free range of motion. Okay, so we don't want to do the exercises, no pain, no gain. We're not doing that here. If you have them doing abduction with below the point of pain, or flexion below the point of pain, extension, say all the way around when you're doing the exercises. Spinal manipulation, again, really important for the cervical and upper dorsals, even all the way down to the SI joint, because the latissimus will go down, tie into thoracolumbar fascia. It can be affected, so you definitely, that's where I think we have an edge over the physical therapist, because they just treat the problem. And kinesio-taping post-therapy prior to the rehabilitation. I like to do that. Like, I'll do some soft tissue and stuff, clean them up, tape them, then have to rehabilitation exercises. Helps with the fascia, muscular contraction. Rehabilitation consists of exercise within the pain-free range of motion. We talked about that. Manual muscle testing to determine weaknesses. Again, when you're doing your manual muscle testing, make sure that you do not try to overpower the patient. You just want to put them in position, test internal rotation, external rotation, and do that horizontally with the elbow up against the side. I can't tell you how many times I see people at the gym holding weights up and doing they're abducted external rotation, and they're doing external rotation exercise with weights. All the studies show that you incorporate more muscle fibers of the infraspinatus and teres minor when you have the arm, the elbow at the side doing external rotation. And if you don't have a band, you're doing it with a dumbbell or something, have them lie on the unaffected side and have them do it that way. Focus on weaknesses within the pain-free range of motion, increase range of motion within patient tolerance, spinal manipulation, as we talked about. Check the scapula, if there's any scapular adhesions. You can do some release on that. Not big, especially depending upon, I would not be doing manipulation of the joint with a labral tear, okay? Or post-surgical. Now, most of your athletes, if they have a slap or tear, posterior labral tear, they're probably going to get the surgery because they want to compete still. But your older weekend athletes may not. But like a meniscus in the knee, if you don't do the surgery, you're going to have those flare-ups where, you get the click, you get the minor swelling and the pain. And so if they're athletes, they're probably most likely going to get the surgery. And you'll be doing this stuff post-surgically. As the pain decreases, the stability increases, we move to active rehabilitation. External rotation with electric stim, wall ball exercises are good. Band exercises in pain-free range of motion, stabilization exercises, and the postural exercises. We're going to go over these. I got a couple of picks coming up. Here is, like I said, he's a dumbbell. He's a towel between the thorax and his arm. Give a little space, but greater range of motion. The pads are placed on the muscle belly of the infraspinatus. You can also put pads on the teres major and minor if you like. And what you do is you have utilizing something like a TENS unit. Could be just an EMS unit on a burst mode so it contracts, and when it's contracting, he's doing his exercise, externally rotating. I usually use the Russian stim setting on the EMS unit. It works very well. Wall ball exercises. Again, it's a closed kinetic chain exercise. So it gets them. They do small circles here. Make sure that they have good alignment, and basically it's just a stabilization exercise. Try to do a little stability of the rotated cuff, give it a little proprioception feedback, which is very important. Closed chain exercises are for proprioceptive purposes. That's why we do it ankles. We'll do wobble boards and stuff, right? Here's band exercise, and the therapist provides the external resistance. So on eccentric contraction, okay? So when he's concentrically going out, and when he's eccentrically going back, you could provide fix that one hand on the elbow, keep it against the side, the other hand slight pressure against the back of the hand to give some eccentric force. Okay. Rhythmic stabilization exercises. He's using wobble board, or you could do these with a BOSU. Works very well. But basically, this is when they're more stable. You're not doing this in the beginning of your rehab protocol. But again, it's good for proprioception. It's good for stabilization, and so forth. Okay? That was not supposed to be in there. Okay. All right. So upper crust syndrome. Now, with all the stuff we talked about so far tonight, this is probably where it all starts, because when you have the upper crust syndrome going on, you have postural issues that lead to shoulder problems. So that's why I want to talk about this. So what is upper crust? Well, weak cervical flexors and weak rhomboids. So they usually have rounded shoulders, forward head posture. They'll have tight suboccipitals, tight traps, and tight levators, and tight pecs. So we release the tight muscles, we strengthen the weak muscles, right? So those are what we would want to do in this situation. And the reason why is we're trying to improve the posture, to improve the biomechanics, so the patient can fully heal properly. We have some postural exercises for that. You got the corner row, you got the cobra, you have a scapular wall hold that you see her doing in the middle here. Some postural exercising here, which works great, obviously. All right, and then scapular push-ups, where you can see how she's working the scapula with a push-up motion. It's not a push-up, it's a scapular push-up. So basically, their scapula are coming back and the trunk's dropping, but they're not flexing their arms to go down to the ground. Okay, but these are some great exercises for posture. Of course, we have the band exercises, and whether it's shoulder flexion, extension, future, some external rotation. Do not do this one. There's more external rotation. W exercises, grabbing, have them wrap the band around both hands, elbows tight to the side, and they go wide out like that. The hands go out. So keeping the elbows to the side. So the W exercises to strengthen the rhomboids, middle fibers of the trap. Kinesio taping of the shoulders, a couple of techniques. This is a spider tape that's pre-cut. This kinesio tape, I don't do that. I mean, I'll run one over the supraspinatus tendon, I'll do one coming up for the teres, infraspinatus, maybe I might run another one off just above the spine and the scapula coming this way. If they have bicep tendonitis, definitely run one down here. So you're just trying to assist the affected muscle, whatever the muscle it is, so you don't have to tape the whole shoulder up. All right, so that was enough of that. Talked a lot about subacromial pain syndrome. We talked about rotator cuff tears. We talked about labral tears. Talked about upper cross and the importance of and the rehab therein, and working with the patients that way. Okay, so a little shift in gears here. Little league shoulder. If you deal with your kids are playing little league and so forth, that you could be a great influence on them, on educating them. There are pitch counts out there. And they're there for a reason, so these kids don't hurt themselves. This is probably one of the most detrimental injuries that can occur to a kid if they're throwing too much. Little league shoulder is an overuse injury, cause stress to the humerus nearest to the shoulder joint. The stress can cause a widening of the growth plate and resulting in pain and swelling in the region. The following factors contribute: repeated overhead throwing without proper rest, pitching and throwing with improper mechanics, lack of muscle strength in the shoulder and upper back. It can mimic a Salter-Harris type 1 growth plate injury. You'll see why, because when you see the x-ray here, you can see how there's a separation in the growth plate along here. Salter-Harris 1 subcapital femoral epiphysis would be the first thing that comes to mind, where if it was a Salter-Harris 1, this humerus would be sliding this way, and the humeral head would be staying there. So it's more like Osgood-Schlatter's, where in Osgood-Schlatter's, if you remember the patella tendon pulling away the tibial tuberosity from the tibia. This is a separation of the growth plate. It's very painful. These kids are chronically inflamed, and they're not getting better, and they're still out there pitching or throwing or whatever, and they have to immediately be taken out of activity. You need to get an x-ray. I've diagnosed 2 of these in the last year. Icing the region and reducing swelling, and once they do that, usually 4 to 6 weeks or up to 3 months of rest, then we get them back slowly with rehabilitation, range of motion exercises, and so forth, and then trying to correct their mechanics. That's really important, because a lot of these kids are not taught to throw properly. So that's important. And if you're not the person for that, fine, but talk to the coach. Tell the coach, say, listen, maybe we need to get him to a throwing or pitching coach or something that can look at his mechanics. Trends in presentation management and outcomes of Little League shoulder. So with the rising participating youth sports in baseball, proximal humeral epiphyseal or Little League shoulder is being seen in increased frequency. This was, I believe this is an orthopedic group, and they did this study, you see, over, 95 patients, 93 males, 2 females. Mean age was 13.1, ranged from 8 to 16 years old. The number of diagnosed cases increased annually over the study period. All patients had shoulder pain with overhead athletics. Secondary symptoms included elbow pain, 13% of the cases, shoulder fatigue or weakness in 10% of the cases, mechanical symptoms in 8% of the cases, while the majority of the patients, 97% of them, were baseball players. 86% of those were pitchers. 8% were catchers. 7% other positions. A small subset, 3%, were tennis players. Physical examination, 30% reported to have glenohumeral internal rotation deficit. That's GERD. And they don't have, if you had them in a supine, and you can do this with your throwing athletes. And if they have, you have a throwing athlete has an injury, you put them in a supine position, horizontally abduct their arm, and then it's like an apprehension test. But if you notice, you should have 180 degrees of range of motion from going extending and then all the way back to flexion. And GERD is when they have a limited internal rotation instead of external rotation in that position. They tend to respond poorly to treatment, so it's really important to identify it because it needs to be stretched out. Treatment recommendations include rest for 99% of the cases, physical therapy 79% of the cases, change of position when they return to play. Average time of full resolution is 2.6 months, while average time to return to competition is 4.2 months. Recurrent symptoms were reported in 7% of overall cohort at the mean of 7.6 months after initial diagnosis. So, pretty significant injury. And I have also just had one just 2 months ago, but it was a softball pitcher. We're going to talk about that too tonight, shortly. Their conclusion was that Little League shoulder is being diagnosed with increased frequency, while most common in male baseball pitchers. The condition can occur in females, youth catchers, and other baseball position players and tennis players. Concomitant elbow pain may be seen in up to 13%. Rest and physical therapy recurrent symptoms may occur in a small subset of 7%. That's what they said. So, almost 1/3 of Little League shoulder patients had GERD. So we got to look for that GERD. And shoulder, softball shoulder. Okay, this is my. I made this up because I'm seeing this a lot in practice. I treat a lot of youth softball pitchers, and these girls are being abused. I mean, they're out there pitching 3 or 4 games a weekend. I'm like, if you have any hope of your daughter, you're trying to get a scholarship for your daughter, she won't have an arm left by the time she gets to college. So it's just crazy. Injuries in girls softball is on the rise. Need to identify the biomechanical stresses on the shoulder from windmill pitching. Correcting biomechanics may reduce injury. Treatment of injuries need to include full restoration of strength and stability of the shoulder, improving posture, strength of the core, all the above. And that's why these kids are getting hurt, is because they don't have the core strength, and they're using other biomechanics to get throw the ball harder or faster. The kinematics. This is written by. No, it's not this one. Maybe it's the next one. A softball pitching. No, it is. This was one of my instructors from my diplomate program. He's a physical therapist in upstate New York, and he sees this a lot up there. So a significant number of time loss and injuries to the upper extremity of the elite windmill softball pitchers have been documented. Number of outings and pitches thrown in 1 week for a softball pitcher is typically far in excess to those seen in baseball pitchers. Shoulder stress in professional baseball pitching has been reported to be high and has been linked to pitching injuries. Shoulder distraction has not been studied in elite softball pitching population. Their hypothesis was that the stresses of the throwing shoulder on elite windmill pitchers are similar to those found for professional baseball players. It's a descriptive laboratory study, and they studied 24 elite softball pitchers during the 1996 Olympic Games. The results were that the shoulder distraction stress averaged 80% of the body weight for the Olympic pitchers. 69% of the variability in the shoulder distraction can be explained by a combination of 7 parameters related to pitching mechanics. Their conclusion was that excessive distraction stress on the at the throwing shoulder is similar to that found in baseball players, which suggests that windmill softball pitchers are at risk of overuse injuries. And well, that wasn't Dale's article. I think it's coming up still. This is the biomechanics in youth pitching here. Limited research attention has been paid to the potential harmful windmill softball pitch. No information is available regarding lower extremity kinematics in softball pitching. As we were talking about, that core strength is necessary for all athletes. If there's anything you're going to do with your young athletes in the beginning, it's not the weight room, it's the core strengthening, it's the plyometric exercises, it's balance, it's strengthening closed chain strengthening, maybe a little bit squatting and so forth, but it's more balance and core strength. They need to have that. That's where the injuries begin. Their results in this study were that elbow and shoulder joint loads were similar to those found for baseball pitchers, college softball pitchers. Shoulder distraction stress averaged 94% of the body weight of the youth pitchers. So it's 94% in the youth pitchers. What was it again in the other ones? Was it 80%? So pretty high stress on the shoulder. So the excessive distraction stress and joint torques at the throwing arm, elbow, and shoulder are similar to those found in baseball pitchers, which suggests that windmill softball pitchers are at risk for overuse injuries. Normative information regarding upper and lower extremity kinematics and kinetics for 12 to 19-year-old softball pitchers has been established. This is Dale's paper, okay? He's a PT, DC, strength coach, and a diplomate in sports medicine. While baseball takes injury prevention of the shoulder and elbow into the 21st century, girls fast pitch softball is languishing in the 1930s. Over the last several years, I've seen a decrease in the number of baseball-related throwing injuries in teenage boys and a rise in the number of softball-related throwing injuries in teenage girls. The reason is simple. While baseball has chosen to make the attempt to protecting and cultivating its future product, the sport of girls fast-pitch softball has chosen to continue its abuse at the expense of its future. Apparently, I am not alone in my opinion. The world's foremost authority on the subject of throwing related to injuries is Dr. James Andrews. In his 2013 book, Any Given Monday, wrote, "There is a common belief that throwing underhand is a natural way to keep players safe from injury, but this is definitely not true. The repeated movement and velocity of the pitches thrown, even in windmill style, are now even tearing the Tommy John ligament, resulting in collateral ligament injury." That's at the elbow. Pitching limits matter in softball as much as they do in baseball. Dr. Andrews and I are not the only experts in the field that believe injury prevention measures need to be implemented in softball. You can also find former players that believe that they were overused during their careers. The way to protect young softball arms is readily available. This is a digital age, and the information is out there. The question is, why can't we get the parents and coaches to read it? This is their pitch count recommendation for softball. Very similar to the baseball. If you look up Little League pitch count, you'll find the same, pretty similar to here. 8 to 10 years old, 50 pitches a game. Usually in baseball, if they pitch 50 pitches in that age range, they have to rest for 4 days. Girls, 10 to 12, 65 pitches, again, rest for 4 days. 13 to 14, 80 pitches per game, rest for 3 to 4 days. And then 15 and older, 100 pitches per game. Topic of performance limits much. They'll have these girls pitch 50 pitches one game, 100 pitches the next game. It's insane. And I tell my patients, I say, you're setting your daughter up to, she's never going to make it to college. I don't care how good she is now. She's 13 years old. Her shoulder will be gone by 16. I said, you got to stop this. And his coach has got to stop. You got one good pitcher. Their conclusion was the topic of performance limits is much different on softball than baseball. It has never been acceptable for a baseball pitcher to pitch back-to-back games. No way. You got to take, look at the World Series. They pitched 2 games. The guy who pitched game 1 pitched game 5, and the guy that pitched game 2 pitched game 7 or something. I mean, there's always rest, so the injuries aren't there. Some sources allow softball pitching on 3 consecutive days with 2 to 3 games per day. This is a formula for disaster, and it is. So if this is going on in your community, speak out. These girls need your help. Here are the modified performance limits. Girls 8 to 10 years old, 1 day of pitching with 1 day off. Girls 11 to 12, 2 days of pitching, one game per day, with a total pitch count of 95 pitches and 2 days off. For 2 days with 1 day off. Girls 13 to 14, 2 days of pitching, 1 game per day, with a total pitch count of 115 pitches for the 2 days, not each day, with 1 day off. And girls 15 and older, 2 days of pitching, one game per day, with the total pitch count of 140 pitches for the 2 days and 2 days off. So it's not quite like baseball, but they do need to rest. When we move on, how do we manage these? Well, patient presents with pain in the upper arm, throwing after throwing also. They may be associated with weakness and their loss of throwing velocity. That's usually when they start complaining, when they notice that they're not performing, and their pain starts to get worse or their velocity drops. So immediate rest from all throwing activities and an icing regimen to 20 to 30 minutes every 3 to 4 hours is implemented. And then if the symptoms persist, you get x-rays of the shoulder. One of the girls I diagnosed had Little League shoulder. She was out for 4 months. If x-rays are positive for GP injury, growth plate that is, total removal for 3 to 6 months. If in-office therapeutic modalities, you can do laser, ice, EMS, light stretching, passive modalities work. Laser and light stretching is a good way to start. I usually have them rest, and I have them doing some stretching at home. Rehabilitative strengthening, I'll usually give a band and have them start doing some band exercises at home when usually after 2 to 4 weeks. And just be diligent with them, docs. I mean, they need you. All right, adhesive capsulitis. Not something you think about too much with sports or athletic injuries, but it does happen. Usually the traumatic type. Not so much. We're not talking about the secondary adhesive capsulitis, which is due like with people that have insulin-dependent diabetes. Parkinson's, cardiac, all that kind of stuff. Yeah, you can see that with those patients. But sometimes you can see, you'll see it with the post-trauma. You'll see it if they're guarding with partial rotated cuff tear. They can develop it and so forth. So you definitely have to do a good history, make sure there's no comorbidities going on. You can see that more in your 30 to 40-year-olds and above. When you're younger athletes, it's probably traumatic and they're guarding. Development. Glenohumeral capsule ligament develops contractures. Limitation of range of motion ensues, leads to severe loss of range of motion guarding, and then the frozen shoulder develops. They're very difficult to treat. If you haven't treated 1 or 2 of these already, I've treated probably about 20 of these over the last 3 years. They're hard to treat. Adhesions develop between the tendon and the long head of the biceps and the subscapularis, and you can see from this diagram where the anterior fold of the capsule here, where it attaches to the anterior portion of the scapula. Here's the subscapularis tendon. Remember I told you it's closely related crosses over the bicep tendon. And you got the intertwining capsular ligament going in there. Here, normal joint with normal position, anatomical position. The anterior capsule folds. In this situation, you can see it's inflamed. Primary classification is insidious, idiopathic, very gradual onset with a progression of symptoms with no known precipitating event. Not uncommon for a patient to complain of shoulder pain and then it is realized their loss of range of motion. So that's your diabetic, usually someone like that. And then secondary is due to trauma, immobilization. Patient usually notices the pain from trauma and as loss of range of motion ensues. They guard the shoulder, and then there's a freezing that starts. So it begins. Phase 1 is a freezing or painful stage. Patients may not present during this phase thinking pain will resolve. The pain gets worse and range of motion decreases, leading the patient to seek out treatment, usually 3 to 6 months into the scenario, and then it's characterized by acute synovitis. Phase 2 is a frozen or transitional phase. It's the loss of range of motion and pain at the end of range. It usually leads to muscular atrophy from disuse. Phase lasts 4 to 12 months. So these are, you're trying to break this up, right? So hopefully they come to us in phase 1, right? We can get in there and try to stop the progression. Well, if they come in when they're in phase 2 and it's already frozen, you're going to have a hard time getting this moving. Sometimes I've even referred them for manipulation under anesthesia or surgical release. So it's really difficult for some of these patients. Corticosteroid injection into the joint to try to decrease the inflammation, try to give you a little bit more chance to work with releasing some of the adhesions. One lady, we did the extracorporeal shockwave treatment over the area. That helped. That seemed to help a lot. Actually increased the range of motion quite a bit. So it is difficult to treat. Then there's the thawing phase, and this is from 12 to 42 months, a gradual increase in shoulder mobility. I mean, I would think that this is somebody who's not getting treated if they're 12 to 42 months. I mean, I tell these patients when they come to the office, I say, listen, you have adhesive capsulitis, so better known as frozen shoulder. I said, it's going to take probably 6 months to a year for you to get full function back with us treating you. So it's just, you're going to have to treat them twice a week in the beginning, and because they can't take more than that. As you go in there, you only want to release one range of motion a day. If I'm working on a subscap in the anterior capsule, I mean, they're finished for the week on that side. Now, if I'm going to work the next time they come in, I may work the external rotators. We do some trigger point therapy and stuff. Work the trap, work the back, the posterior aspect of it, because they can't take the pain. Always begin with the history. Ask questions searching for possible injury, how it began. Usually involves a non-dominant extremity, easier to protect and hold close to the body. Pain over the deltoid region, limited range of motion, both active and passive, flexion, abduction, external rotation. Patient usually has comorbidities. In your older population, and diabetics are classically get this. So, I don't know if it's the high sugar and it causes an irritation, and that's why they're more, common to get it, but they do. Inability to sleep on the affected side. Physical exam reveals marked limited range of motion. Even in the initial phase, the range of motion can be limited. Nears and Hawkins-Kennedy's testing may be positive, but likely from internal impingement of the capsular stretch and capsular stretch. Diagnosis is done through exclusion. So you're trying to make sure you rule out rotator cuff tears, labral tears, bone contusions, subacromial bursitis, those type of things. Screening X-rays always recommended. You want to rule out any degenerative change in the shoulder. Treatment, conservative treatment consisting of deep tissue massage, capsular stretching, ART, rehabilitative exercises for the last 2 to 20 weeks. If treatment is not successful, arthroscopic surgery release has been successful in reducing the lesions and restoring range of motion. Bone stretching exercises are to be followed regularly, and they have to. Rules for treatment: never force range of motion. Work on one range of motion per visit, like we were talking about. Do not overwork the muscles due to atrophy and weakness. The tendons are frail. Okay, so be careful with these patients. Keep the joint moving. Instruct the patient on home exercise, including passive and active range of motion. No ice therapy for these. Causes contractions and restriction. So it's a chronic thing. Heat is your friend. Ultrasound is good for pre-work too, because you want to continuous ultrasound produces heat, and you can get deep heat for the patient. And here's a picture of it. So you can do some deep heating. Sometimes this is showing ultrasound of the anterior shoulder, but most likely you're gonna have to try to get underneath that shoulder and get to the anterior capsule in the armpit there. Pole stick exercises are my favorite ones to send them home with, because you can give them range of motion exercises. The non-affected arm could help the affected arm and passively push through ranges of motion. Some stretching exercises, some more pole exercises, doorway stretches. You see the one, what they call a sleeper stretch? This is for GERD right here. So they lie on this is the affected side, and you see how they're lying, and they fix the arm and shoulder here, and you push down at the wrist towards the floor. Internal rotation. That's the one you do for the baseball and the softball, but also frozen shoulder. His therapist working, doing some stretching, stabilizing the shoulder. It's a nice move, getting in there and working that shoulder area there, the lat, the subscap. Pretty painful stuff if you haven't had it done to yourself. Another technique to try to work the rhomboids, also scapular adhesions that may be there. Okay, try to work on that a little bit too. Obviously, if they had a supraspinatus tear, that would not feel good, right? Because that's an inferior stretch position, inferior scratch. Mobilization, again, you're not manipulating these. You're mobilizing them. I've even used the Mulligan belt on these sometimes, and I don't know if you guys are familiar with that, but it's a strap it around. Strap it around here and around my waist, and then I try to distract the humerus this way as I'm mobilizing and inflection like that. Okay, I do that with the hip. I do it with this. That's it. That's all I got, docs. We got to do 2 poll questions. That is my email if you have questions. Doc, remind me if for those laser, I'll look that up for you if you shoot me an email. All right. Labral lesions are best described as SLAP, posterior tear, posterior fraying, or all the above?
And we are only missing a couple, so I'm going to give about 10 more seconds for responses. And there you are, Dr. O'Hara.
All right, Vince. Yes, it's all the above, docs. Those are the three that we talked about. All right, what do we got? And then last one on adhesive capsulitis is related to which systemic problems? We talked about insulin-dependent diabetes mellitus, immobilization trauma, cardiac pulmonary disease, thyroid disorders, all the above.
And there you are, Dr. O'Hara.
All the above. That was an easy one. All right, Vince, when do I teach next year, right?
Thank you again for choosing CCED seminars for your chiropractic continuing education. We strive to make your experience seamless, professional, and enjoyable. Just a quick reminder. Your course video played in a separate browser tab from your homepage. Beneath the video, you'll find the course notes. Feel free to download them now. Once you're ready, go ahead and close this tab and return to your CCED Seminars account page. After refreshing the page, you'll see the Take Test link appear. At the end of your exam, simply refresh again to reveal the Print Certificate link. That's it, congratulations. If you enjoyed your CCED Seminars experience, we'd be honored if you shared it with others. And if you have any questions or unmet needs, our CCED Seminars team is here to help.